Yes, a good morning, good afternoon. I know we are joining in from various parts of the world. You're most welcome to today's webinar. We'll be talking about community and public engagement of adolescents living with HIV and AIDS. Main point of discussion is the modality of viral load monitoring to improve viral suppression in East Africa. You're most welcome. And I'm today's chair. I'm Dr. Benjamin Watiaba, a medical doctor based at Uganda Virus Research Institute, and a study coordinator of the East African Point of Care HIV viral load. So before we go further, a few housekeeping rules just to ensure that we benefit from this webinar. I just want to alert you that the webinar is being recorded and will be shared on the Global Health Network, the website, if you want to listen more after this. And due to the number of participants, your camera and microphone are disabled. So if you want to communicate to use the chat, please use the chat feature for introductions and to report any technical issues. And we have our team in the background that will be able to help you sort out what you'll be experiencing. And then also we have the Q&A feature to post your questions. You can post it anonymously. And lastly, we will try to get through as many as possible in the dedicated Q&A session at the end of the webinar. And for questions that we may not, maybe we may be able to reach out to you individually. Yeah, so those are our housekeeping rules. As earlier introduced, Dr. Benjamin Watiaba, a study coordinator based at Uganda Virus Research Institute here in Uganda, and I'll be chairing today's. I'm happy, and I'm joined by a team of senior panelists experienced in different fields. We have Madam Elinor Wanyama-Chemonges, who is the co-PI on the East African Point of Care viral load and at Uganda Virus Research Institute, and she heads work package 6, which is community and stakeholders engagement. We have Dr. Magololo Mutes Fiona, a medical service technical lead at Tasson Lago here in Kampala, Uganda. And we'll be joined later by Jason Yiga Ediga, an educator and based at Alev Medical Services. Then we have a senior doctor, Dr. Stephen Watiti, a founder of Watiti Foundation and an influencer in the HIV management here, not only in Uganda, but East Africa and globally. So this is going to be our agenda for today as introductions that I've already done. And our first presenter will be talking about community and public engagement findings among young people living with HIV. Then we shall have our second presenter who will be talking about point of care, the role of point of care in improving viral load suppression. Then we shall have some co-developed communication strategies, and these were developed by young people. We shall have some presentations, videos. Then the last two sessions will be a session about adolescent and youth perspective on communication and engagement strategies. And last but not least, strategy and policy directions to improve HIV viral load suppression among the youth by Dr. Watiti, and then Q&A session at the end. Yeah, so we are happy that a number of us have really joined in, and I just want to congratulate all of us. I know, as I said, people have joined in from all over. As per yesterday, we had almost a total of 485 joined in for this webinar. I know many others are still registering, people from East Africa, West Africa, Southern Africa. We have people from Europe. Please, you're all most welcome. And we appreciate, we hope you'll be able to benefit from this webinar, as we are only hours celebrating the World AIDS Day. So these are some of the resources. I know you may really want to visit these websites. Actually, I do invite us to visit these websites. The ESSR, the Global Health Network.org. And here we'll be able to find all resources pertaining what we have done, and many other webinars that have happened, and some other short courses which you'll be able to benefit. We have the next one, aheli.org, because there's other people actually who sponsor this. Then we have our website here at uv.org.go.ug and TASO Uganda. And these are people who have provided us over 4 sites that are participating in this project. So our first presentation, which is community and public engagement findings among young people living with HIV, as I've said, is going to be presented by Madam Elinor Wanyana Chemonges, who is heading work package 6 community and stakeholders engagement. She's an experienced social researcher, and she has done a lot of work. She has research experience of over 10 years, and she has been working with these people on this project for a period of 3 years, and we are still moving. So let's listen to her and hear from her experiences. Madam Elinor Wanyama, you're most welcome.
Thank you very much. I'm glad to have you all. I'm Elinor Wanyama Chemonges, and I'm the Community and Stakeholder Engagement Lead on the East African Point of Care Viral Load Monitoring Project, on which this engagement of youth is hinged. So this is a subset of the East Africa Point of Care Viral Load Monitoring Project. We are specifically interested in engaging young people and finding out their perspectives on how we can best engage them and how we can publicize the findings of the East Africa Point of Care Viral Load Monitoring Study. So you're welcome to join me just to find out some of the findings that we have so far come across, and these are perspectives from young people themselves. So we were looking at community and public engagement of adolescents living with HIV/AIDS on the modality of viral load monitoring to improve suppression in East Africa. And the particular modality that we are looking at is the East African Point of Care Viral Load Monitoring Project. So for this sub-study, the first objective was to engage youth for knowledge transfer on the modality of viral load monitoring for improved suppression. The next objective was to co-develop an approach of to enhance public understanding of the science of viral load monitoring to improve viral load suppression. And lastly, the objective was to promote youth-led engagements and advocacy on developments in HIV service delivery. We had a simple methodology. We had a series of meetings, and the first one was to have initiation meetings with organizations that are participating in the East Africa Point of Care Viral Load Monitoring Study. So we made 2 initiation meetings to talk to the staff and the people that are implementing this study in 2 sites. We then had 2 workshops with the young people in which we were co-developing the communication methods that were best suited for them. We then had 2 WhatsApp groups formed at the 2 sites, and the WhatsApp groups were mainly for the young people to engage themselves to work together in co-developing these modalities and methods for communication. We had other staff joining the young people to support them, to guide them as they co-develop. Then we also engaged youth-led HIV/AIDS organizations, as well as some key stakeholders. And we are glad that some of them will be joining us in this webinar as speakers. We also had a youth vibe challenge, and this was a competition for young people. The target population was 15 to 24 years, and these young people worked very hard to see and develop methods in which they think that they can best be engaged. So we had a competition, and we had judges who were able to adjudicate, and give results at the end. So for the Youth Vibe Challenge, we had a number of outcomes that we recorded. We had 3 sets of drama. These were short skits that were presented by the young people. Then they composed 2 songs. They also composed 5 poems. They did 2 dances, and we had 2 motivational speeches. All these were about point of care viral load monitoring. And according to them, they thought that these were some of the best methods in which we could communicate the outcomes of the East Africa point of care viral load monitoring findings, and also future engagements with young people. Those are the best methods that they reckon that we could use. When we engaged the young people in a workshop, we had them tell us a number of methods which they think are the best for communicating messages on HIV, including viral load monitoring. And they said dances, songs, drama, motivational speeches, and they also said that they could also hear and take messages from respected community members. One of them told us that it's not just enough to have these methods, but to actually have the young people participate in developing the messages and relaying the messages. For example, one of them told us that taking part in singing or in drama, they cannot forget the message once they have participated. So we think that in future, whoever is doing research with the young people, the best way of disseminating these results is to actually engage them in developing messages and relaying the messages themselves. Among the methods for communicating HIV messages, both to those that are infected and those that are affected, they told us that one-on-one counseling sessions are actually the best. And they said that getting one-on-one sessions with healthcare workers, with peer educators, and professional counselors was one of the most effective ways. And one of the young people told us that as an individual, when they sit with a counselor or a healthcare worker, they are actually able to ask questions, they are able to relay their fears, and they get personal responses with regards to the questions or issues that are at hand. So one-on-one counseling sessions is one of the best ways of relaying HIV/AIDS messages among young people. We also got to learn that young people enjoy the company of each other, and they actually listen to each other. So they said that if we organized meetings of peers, they could best understand each other. And many of them obviously said they could not afford to have meetings on their own, but they encourage us to facilitate and encourage peer support groups for relaying HIV/AIDS messages. Of course, social media came out very strongly as one of the best methods, and we also used this in our study. We used WhatsApp, but there are a number of platforms that they can use: X, Instagram, Snapchat, LinkedIn, YouTube, TikTok, Facebook, and a host of others. So young people and gadgets, they understand that language. So that is one of the best ways in which we can communicate messages. We also discussed challenges in the existing communication modalities. For a long time, we have used journals, we have used posters, brochures, we have used seminars, meetings, conferences. And one of the things that they are telling us is that some of these communication methods have challenges. For example, in social media, if left on their own, there are some miscommunications that happen on social media. So they need to be guided. And if researchers, if healthcare workers can start using social media to communicate, they will be able to do away with these miscommunications. Then some of the messages that we relay are sometimes very inconsistent with the youth's realities. For example, when we tell them to abstain, for example, from sex, if we tell them not to use drugs and their own ARVs, we assume that these people don't actually have these temptations, they don't have these challenges. But youth and young people with HIV and AIDS are also faced with these challenges. And then they also say that there are sometimes judgmental attitudes among counselors. Some of the comments, you can read them. For example, if one went and they are pregnant, sometimes they tend to be judged. And then TV and radio, their concentration span is very short. So it's very difficult for them to listen to these long programs. Then we also expect family members to be very supportive, but oftentimes the family members are not counseled enough, and they give contradictory messages to our young people. So we asked them about why they tend to have viral load, their viral loads very high. And it was interesting to see their perspectives. They said the biggest problem is inconsistency in taking ARVs. And they told us that they are told during counseling that they need to eat before taking their medication. So they told us that oftentimes when they have nothing to eat, then they miss out on their medication. Sometimes, especially the older youth, they work and they work inconsistent hours, especially shifts, night or day. And whenever they, on night shifts especially, they tend to miss out on their medication. As earlier stated, young people like staying together and interacting with each other. So whenever they stay out late, they stay nights over at friends' places, they also miss their medication. We are also aware that young people also take alcohol, and some of them are actually engaged in illicit consumption of illicit drugs. And they told us that whenever they take drugs, they take their ARVs. So these are issues. And also when they are stressed or are depressed, they also tend to give up on life and not take their ARVs. So these are some of the unique explanations that we came across in our study. So the way forward and the recommendations. We recommend that we train more peer educators because young people want to listen to themselves. They want to hear messages from each other. So we should encourage peer educators in relaying HIV messages and counseling the young people. Then we also encourage youth participation in developing and delivering HIV messages. We also need to give balanced messages cognizant of the youth realities and lifestyles. And then, as we have seen and will be seeing later, music, dance, drama, social media are the preferred methods of communication. And further still, it's not enough to tell the youth to abstain from drugs, from alcohol, from sex, but we actually need to go further and provide skills and education on how to say no to some of these temptations. And lastly, we still need to conduct more comprehensive research and promote messages by youth themselves about HIV and AIDS. Thank you very much for your attention, and we shall be listening to your questions. Would like to acknowledge the team that worked on this research, Professor Janet Seeley, Dr. Dennis Sesanga, Lazaro Mujumbusi, and Benjamin Watiaba. And these are the organizations that have supported this study and continue to support the East Africa Point of Care Viral Load Monitoring Project. Thank you very much.
Madam Elinor Wanyampi, detailed presentation about point of care and the challenges, the engagement. So please, if you have questions, as I said earlier on, please feel free to text them in the Q&A section, which I'll be able to reach to them later. And now I'll be able to invite our second presenter, who will be talking to us about what does point of care really mean. What's its role in preventing HIV? I mean, in helping us to attain viral load suppression. Dr. Fiona Mutes is experienced and is working with one of the biggest partners here in central Uganda, that's Tasso, Uganda, and she's the lead of Tasso Mlago. Dr. Fiona, you're most welcome.
Thank you very much, Dr. Benjamin. Greetings from whichever part of the world you're joining this webinar from. I am Dr. Fiona Mutesi. So currently in Uganda, we are at 81, 96, and 82%. That means that 81% of persons living with HIV have been identified. And of those who have been identified, 96% of those who are identified as positive are on treatment, are on ART. And of the 96% that are on ART, only 82% have a suppressed viral load. Okay, I hope you are together with me. So this means that our greatest challenges in achieving the UNAIDS goal is identifying new positives, and secondly, having more people who are on care suppress their viral load. And if you are in East Africa, you know that our biggest challenge with the suppression of viral load has been among the children and the young adults. That is usually between the range of 5 to 25 years of age. Those have been the most problematic groups in achieving suppressed viral load because of multiple socioeconomic as well as psychosocial challenges. Okay. So the tools that we can utilize to support the UNAIDS goal, of course, is HIV testing, ART, but also routine viral load monitoring. So viral load monitoring is done to monitor virologic response to treatment. There are very many other ways to monitor response to treatment, but viral load has been found to be the most important, but also the best marker for how clinically, how the client is progressing, both clinically and immunologically. These are the different durations at which we perform viral load testing for the various groups, but important to note is that for children who are below 20 years, we do viral load monitoring every 6 months, and majority of the people who are in the study group belong to this age group. So viral load can be suppressed or unsuppressed, and here in Uganda, the Ministry of Health launched new guidelines in 2022. And according to the new guidelines, you have a low-level viremia if your viral load is between 200 and 999 copies. And you have a high-level viremia if your viral load is greater than 1,000 copies. So you'll only be considered suppressed if your viral load is less than 200 copies per mil. Of course, that depends on if the sample taken is serum or if it is a DBS. But nevertheless, it's important to note that we now have a new category of people who we consider unsuppressed with low-level viremia. So the ideal viral load count for each individual is a target not detected, which is usually less than 50 copies. So once you have a high viral load, you are very high target for acquisition of opportunistic infections, the commonest of which we know is TB, and Uganda is one of the highest incidence countries for HIV TB as mapped by WHO in 2022, and herpes zoster, Kaposi sarcoma, among others. When you have a high viral load, you'll only receive a short-term refill of 1 month, regardless of whether it is low-level or high-level viremia. And we give you that 1 month refill so that you can receive intensive adherence counseling, and we can help you to mitigate the challenges that you experience in routine care. It's also very inconveniencing to the work and school schedule. Persons living with HIV and normal individuals like us all, they have socioeconomic lives, they have to fend for their families, and they have to attend school. So this schedule that is moved to in high viral load is very inconveniencing for them, and sometimes it's also a trigger for even further unsuppressed viral load. Okay, so once one has a low viral load, they usually get longer refills and short clinic stays, and that usually enables a healthy and good quality lifestyle. So currently in the viral load testing mechanism, we have a centralized mechanism. All samples across the country are moved using the hub system to a central facility that is in central Uganda. And the minimum amount of time that is taken for these results to return is 2 weeks. And unfortunately, the average is actually 3 weeks. It can take up to 3 months for these results to actually return, and they will be disseminated through an online system to each facility. Next. So what are the challenges in that viral load testing mechanism? The delay of results. For each single decision to be made based on the viral load result, you will have to wait a minimum of 2 weeks to make that decision. And since we talked about the socioeconomic challenges, you do not want your client to return in 2 weeks. So usually we'll give them a month or even 2 to return and check that result, just to be sure that the result will be back. Also, there have been multiple losses of results, and their lack of clear follow-up mechanisms on misplaced samples. If samples for the whole country are being taken to one unit, it's very hard to follow up on this one person's result that is misplaced. Of course, it's also costly to transport samples. There are samples being moved from as far as 400, 600 miles away to come to this one central facility. So the East African Point of Care Viral Load Study is a study that has been investigating feasibility and acceptability of point-of-care viral load testing among children, adolescents, and young adults who have an unsuppressed viral load. And it has been going on for more than a year now at Taswa Mulago, which is an intervention site, like I said. In this study, we have been doing point-of-care viral load testing, and we have found very many changes or differences using point-of-care viral load testing compared to the routine viral load testing mechanism. It has eliminated the cost of sample transfer. It has reduced result turnaround time significantly. The turnaround time has been reduced from the minimum of 2 weeks to an hour. And also that means that the time taken to make clinical decisions for these children and adolescents and young adults has also significantly reduced to about 1 to 2 hours. So I trust and believe that this same result will be can be seen with all the viral load groups, as long as they have, as with all the HIV care groups, as long as they are seen to exhibit an unsuppressed viral load. So it's the same with the mothers, it's the same with the children. If we are able to do a viral load on site and deliver a result, then we can make a quick decision on whether we should initiate advanced HIV disease care for this client, or if they have completed their viral load suppression intensive adherence counseling sessions, if we can now revert them to the regular kind of care. Okay, so what are the disadvantages of point-of-care viral load testing? Of course, it is costly. We'll have to have a machine at each center or at each HIV clinic. And that, yes, is costly. Of course, we also need to train health workers to be able to carry out these tests. That is also a one-time cost, of course, with a bit of refreshers. It's also costly. It can result in longer facility waiting times if we have very many clients who are having to undergo a point-of-care viral load test. So that is why the best thing to do is to prioritize it for only the group that will need it most, which is the unsuppressed viral load group. And then lastly, the amount of human resource available to implement it. You still have every other task, HIV testing, advanced HIV disease screening ongoing, as well as having to run a point-of-care viral load test that will be a bit more demanding. Okay, so that brings us to the end of my presentation. Thank you very much. I look forward to the questions. Over to you, Dr. Benjamin.
Yeah, thank you so much, Dr. Fiona, for that presentation and bringing us on board with the study that is ongoing already, the East African Point of Care in 4 countries, Uganda, Kenya, Rwanda, and Tanzania. And for questions, please put them in Q&A and we'll be able to respond to them as we move forward. Yeah, so I think we'll be able to move to our next item on the agenda, where I shall be listening to some videos, communication strategies that have been developed by the youth. These are youth who are attending care from some of the facilities in Central and Eastern Uganda, and some of them are already participating, or they are participants in the study that's already ongoing. So we just want to hear their views about point of care. It's going to be a video, so please feel free to listen.
That is good, and I like it. she never misses that viral load bleeding.
It's my friend, but this time she didn't tell me what's going on.
Oh,
Yeah.
Now let's first bleed that we see, eh?
Don't worry, Mary.
I know she's a jolly girl. What is wrong today?
Okay? Everything will be fine, just fine. You have hope. You're not the one who is in this. Okay?
Something happened. And then let me first bleed her.
Don't
Just say
feel
cancer.
worried. You'll be
Maria.
fine, okay? Maria.
Okay.
Don't be quiet like
Maria, I
that.
want to bring you your hand. So how was been school, Maria? Maria, it's not fine. Anyway, you don't say counselor. I'm sure it's counselor Jacinta Darrell or counselor Pesha. You'll see one of them. I know they're your good friends. But let's first bleed you today and you say exactly what in your blood.
Maria, don't look like that. Put a smile, smile.
It's not going to pass. I think you listen to what your friend is telling you. So you make.
Hey, my sweetie. So for second more.
So we are going to
If only you just believe in yourself. Oh, all you need is take your drugs every day. Don't you worry about the stories they say, 'cause they will talk much. They will stigmatize your life, discriminating you every day to die in life. But that doesn't make you cry, 'cause no disease is known. Only we need, all we need is stigma-free environment in us. Only we need, all we need is stigma-free environment in us.
A vein pather overdrop, a simple test, a rapid test, a moment of truth, a chance to know, a point of care, a way to go. 4 million people living with HIV, a point of care test can be a lifeline, a tool to diagnose, a tool to monitor, a tool to treat, a tool to empower, a tool to educate, a tool to prevent. Readily available to clients, giving them a bigger smile. Phone to entry, points of making things soft. Get viral test results after a few hours. Giving the client a chance to know if they're suppressing or unsuppressing. Doctors intervene faster to make the right decisions. Leaving hospital early, giving us joy. Oh, what a wonderful services. Point of care testing is more than a test. It is a human in right, a global goal. It is a hope, a promise, a challenge. It is a point of care. Wow. That's all I had.
Yeah, thank you so much. Maybe before we go on, the first one was a skit. And as we saw, people were advocating for stigma-free environment. And then the next one is actually a young, also a beautiful lady called Charity from Tasom Lago, who is presenting her message about point of care through a poem. Then we have another poem from another young lady from Eastern Uganda, that is Tasso Ginger, and you'll be able to listen to her message. Yeah, please, Adam, let's continue.
HIV positive. It is a true point of emphasis. Over years and years, some time back in the 1960s, a disease giant, HIV/AIDS, invaded our country, Uganda. This was a period of terror, and some of us thought it was witchcraft. But then, after thorough research, it came to our concern that it was a virus that was intervening with our health life. Years have come, generations have gone, flowers have dried, worries have ended. Now, I bring to you the good news. We have the point of care. For generations, we've been waiting for our results for over 6 months. At times, we've been told to wait for these results and then we lose hope. Sometimes we give up on taking our medication, but then all is done, all is well, not my word, quoted from Jesus himself. All is done, all is well. It is paid all. That everything has come to pass, and we now have the point of care, rapid results, easy to know, a right to access to medication right and then, and everything will be good on our side as young people living with HIV. It is also worth noting that the young people living with HIV in Uganda, HIV is one of the greatest threats amongst these young people. Therefore, if such an innovation is brought, it brings a smile, a big smile on the mouths of the young people. As I conclude, I'll leave some words with you. I'll say, you're beautiful, you're kind, you're precious, you're unique, you're not too much, you are just enough. In fact, you're almost standing out of God's creation.
Yeah, thank you. That's another young lady from Tasso Ginger, and I like her concluding remarks reading. You are beautiful, you're not too much. Whoever's joined in this webinar, God created you that way, and we just have to know about, we need to know about our HIV status and coexist, support one another, encourage one another. These are the messages that the team here in Uganda has been coordinating with the rest of the youth, and it's interesting to see them get out openly and speak. Yeah, thank you so much. Next, young people expressing their views on how we should be able to communicate and fight stigma and improve HIV viral load suppression. This still from Tasso Ginger in Eastern Uganda. So let's listen to this video briefly.
A drama, a dance, and a song. Give me that. You learn, relearn, and unlearn. Today was a bit smart. Stigmatization. Why stigmatization? Standing there, your eyes gazing far into the distant heads. Stigmatization. Asking questions, too silent for answers. Stigmatization. Your wings will grow and you must fly. The wind blows, the sun rises, and the day begins. A child at school, never in peace. Oh, look at the teacher. Isn't that a stick? He loves a stick more than chalk. He passed told like this. Go down on your knees, bend down for 7. But why? But why should I be treated like this? Just because of my status? Why and why?
Listen to the drum beats. Listen to the drum beats. The drum beats are waking Ugandans to fight stigma.
The battle is over.
We are ready to fight stigma.
I dare to fight stigma.
I stand out to fight discrimination.
We are breaking the stereotypes.
The nation believes. The society norms. To empower the culture.
Empowering generation.
Let's all get involved in the fight against the stigma.
It starts with you.
Children of Africa, down the streets around Africa, listen to the voices crying, so hopeless, in pain, in sorrow, singing, Mama Africa save me, yeah, sauti ya watoto barabarani, talking to Africa. The children of Africa.
No child is born to die, and no mother should die. Giving life.
We need to come together to make a difference. Everyone has a
We are here for you. We are here for you. We are here for you. We are here for you.
Wafuna akabenje, eto taliyo, sawo emuguwe, mukubanga, wene tule nawe, elesanga, silichoni, ogenda kuwangala, abakusabe n'abalala.
We are here for you. We are here for you. We are here
Thank you so much. Our next item on the agenda. I'll be welcoming Dennis Sesang, who will be speaking in as coming to speak on behalf of YIGA, who is having internet challenges, ever since we started Africa Issues. But at least Dennis has been able to connect in the stable network that have been working together. So I would make welcome Dennis Sesang to take us to the next session. Maybe more about Dennis Sesang. He's the knowledge management person here at Uganda Viral Research Institute. And he has been working with the team towards community stakeholder engagement. Dennis, you're most welcome.
Yes, thank you very much, Benja. Yeah, I'll be presenting on behalf of YIGA. So we had a engagement with some of these young fellows. Some of the things that stood out when we asked ourselves, like, why have we been failing to communicate and engage with the youth effectively? There were two things that stood out in the previous engagement, whereby they did mention that programmers, implementers, when they do show that they want to do everything by themselves without engaging the youth, it's something that leaves them behind. So the implementers end up working on the projects from their point of view without having a bottom-up approach. And that's why some of the interventions fail. The second one that came out was late involvement of the youth in programs, especially at the stage when the projects are not yielding anticipated results. So you find that after the implementers have failed to realize the results they wanted, they go out to the youth and try to see what they can do to salvage the situation. So we may be asking ourselves that how can we engage and communicate with the youth effectively? In the previous presentation, my colleague Eleanor did present to you about some of the interventions that were mentioned. So I'll not be repeating some of them, but these are these are some of the key aspects that came out while we engaged with these youth. That the young people should not stigmatize themselves, but learn to love themselves unconditionally. So when they stand out to communicate, to deliver what they have to deliver in terms of information, they should know that they are loved unconditionally, and they should be able to engage with the people they're engaging with without fear or favor. Then programs that are being implemented need to be taken to communities and the ghetto and not at the hotels. This came out really big in that most program implementers take most of these workshops in the hotels instead of going down into the community. So some of these young people find themselves being kept out from engaging and from participating effectively as they should. Thirdly, the young people did request that they need to be put in the front seats so that they can hear what we are trying to say to them. So if we always engage the older people and leave them behind, and we plan programs from the older people's perspective, these young people end up being left behind. Yet the young people better understand how they should be engaged and how best what language should be used, what strategies should be used. So when the young people are engaged in the front line, most of these programs can be effective and yield greater results. And lastly, they did mention that we need to deal with the people who know the youth better and who are also youth friendly. This is very key in that youth friendliness encourages most of these young people to come out and also take on whichever interventions or programs are being programmed for them and for the betterment of their health. Thank you. Over to you, Chair.
Thank you so much, Dennis, for that presentation, giving us the perspective from young people. And I like the fact that you said we need to move these sessions from hotels to these conference rooms to go to the field And I want to give credit really to the people who went out, that they made those presentations from the sites where activities are happening, and they managed to engage the young people, and they were part of the process. So I'm really happy about that, and to give us the perspective from the youth or the young people living with HIV themselves. And last but not least, we have one of our experienced doctor in Uganda who has built really, has put a very big stone on the HIV care, not only in Uganda, as I said, but East Africa and the Africans will be telling us about. He's my teacher, I don't know if he remembers, but at least, yeah, and we have seen and learned a lot from him. Dr. Stephen Watiti, the founder of Watiti Foundation, Uganda. So he'll be talking to us about the strategic and policy directions to improving HIV viral load suppression among the youth. He has been part of that team, and he comes with a lot of experience, and will be responding to some of the questions during that session for Q and the A. Dr. Watiti Stephen, you're most welcome.
Thank you very much. Thank you, friends. And thank you for having me and for that nice introduction. I don't know whether I can be heard.
Yes, Dr. Watiti.
Yes, I'll just show my face. My name is Stephen, and I am a doctor, as you've mentioned. I've been working as a doctor for the last 35 years or so, but I'm now in retirement into health advocacy, especially HIV and AIDS. Yeah, I happened to have started taking ARVs around 1999, 2000, after going down with infections like TB. I've suffered from TB about 5 times. And I also suffered from cancer, sarcoma, and even cryptococcal meningitis at a time when we did not have ARVs. I had actually suffered from severe bacterial infection around 1993. So I've gone through all this. My CD4 count at the time when I started this was less than 160 cells, about 160 cells, less than 200. So I had advanced HIV disease, and the viral load was over 600,000 copies. And the cost, I was also buying ARVs and very many tablets. Actually, I was swallowing. I put there 11, but actually there were about 14 tablets in addition to swallowing tablets for TB and an injection. And the tablets had a lot of nasty side effects. And then I was also very highly stigmatized because I felt ashamed. I felt embarrassed that I had HIV. And never mind, I was a doctor, but I was quite illiterate about ARVs and how they work. So that's my background. And but around 2004, I resigned my job and went to a new place where I noticed that many of my patients, especially young people, were not doing well. So I took a decision to be open about my HIV status with my patients first and foremost, especially children who are living with HIV. Many of them were not doing well. And I started telling them stories about myself. I had lost a lot of weight, a lot of appetite. But now, because of adhering well to treatment, I was okay. When we started ART at that time, we had to wait for people to get 200 cells. We didn't know, of course, many of them died after we started them on ARVs. Later on, 250 cells, CD4 and 350. And they were using even what? CD4 count for monitoring. When we put people on ARVs after that, we would use session. But it still worked, of course, including clinical monitoring and then this immunological monitoring using CD4 counts. It was later, actually, when viral load, I don't remember the date, became the standard monitoring. And now we have even the information, later information that actually an undetectable viral load means this person cannot transmit HIV. And even somebody who had a very high viral load like me and was dying of advanced HIV disease at 47 years, I've now been on ART and then recently I turned 70. So these are the messages. And why I'm saying this is the importance of young people especially use their lived experiences to help other people, young people and all other people. And this is what is going to help us. We are grateful for now that this research is very important. We're producing evidence, but evidence is what is going to influence policy. I am now involved in advocacy and the lobbying with powers that be to change and even practice with my colleagues, doctors, that indeed, if people living with HIV take their medicine with good adherence, even people who are very sick like me, as I mentioned, who had TB, cancer, severe bacterial infection, and even cryptococcal meningitis, can still live good quality lives. I'd lost my wife after some time after living alone for over a decade. I remarried, and I've been married now for 18 years. So really, this should be a good thing. The good thing with this, I don't know whether I have another slide, is that when people, like young people, especially adolescents on ART, are able to get their results well, at the right time, they can use the information to make informed decisions, because many of them are now getting relationships with even people who are negative. We're telling people that if these young people who, some of them were unfortunately being infected with HIV, even from their mother's wombs, that if they're taking medicine and their viral load is undetectable, what they need is not to be stigmatized and to be marginalized, but to be supported so that they can even live in discordant relationships and be able to have babies if they wish, who are HIV negative. So to start with, we are happy that this is there. Of course, it has cost implications like it has been mentioned, but we need to especially roll it out amongst young youth, the people who are bearing the brunt of this disease, like the adolescent girls and young women who need to know, because in my country, these are the ones who are 15 to 25 years who are bearing the brunt of what of this problem. The other thing, and the other people like the sex workers, this because of their work, they need to be given this so that they can know, so that they know how to do it like they do now, and self-testing, whether somebody is positive. Somebody may be negative, positive indeed, but if they are on their treatment and they're taking their medicine well, then they are as good as any other person now we know, and the other subgroups like the MSM. It has cost implications, so we need to start with these few, and maybe even men in my country are the ones who are bearing the brunt of deaths, HIV or AIDS-related deaths. So men maybe need to be given this so that they know, because when somebody is shown there and then, the problem with the testing sometimes it takes too long. So those are my few ideas, but I really want to encourage especially young people living with HIV. Look at me, I've lived with HIV for over 35 years. Most of you are less than 35 years. And I'm hoping to live up to 90. So if I have these things like I can check my viral load, and if it is maybe not up to date, I can be able to talk to my counselor or my doctor, or maybe even any other person who is supporting me to encourage me to do the right thing to do. Because we know if we take medicine with adherence and avoid harmful practices like alcohol consumption or other drugs and eating unhealthy and exercising, it looks like we can live as long as God has, of course, allotted us. Thank you very much, and over.
Yeah, thank you so much, Dr. Watiti, for that testimony and the powerful presentation. Every time you present, you bless so many people, not only in Uganda, as I've said, but your name is known globally, and you've impacted so many people. And Dr. Watiti, I just want to also let you know that there are some questions that we'll be responding to a little later, and I'll be reading them. I think I'll be able to give you opportunity to respond to them verbally as people follow. I know we have audience from all over Africa, and we had a mixture of languages that were happening. And just maybe a brief one is that they start off with the marketplace, and you saw a youth who was coming from possibly from our art clinic, and she was moving with her drugs in the team. and accidentally they fell down, and the colleagues were surprised that she's working with them and she's HIV positive, and you saw the stigma that was portrayed there, and the events that happened. Then the song, another song in Swahili, it was really, people were decrying, you know, the rate or the number of Africans that are dying due to HIV. So we need to be there as they conclude that, you know, like in Uganda, they were saying, Togo, we don't need to lose hope. We need to be there for one another. And this time, I think we are at the time for our questions. Dr. Watiti, I don't know if I just requested you maybe for 2 minutes only. There's a question that which came into the chat. The rest have responded to, but I request you to respond to this one. What strategies is Uganda implementing to mitigate new infection among young people, especially sexual? I think they say sexual intercourses, maybe sexual health workers. And what are some of the things you are doing to promote viral suppression among young people? I think that has been responded to. Dr. Watit, maybe in 2 minutes only, could you possibly respond to that?
Yeah, thank you, Dan. Thank you, everybody, and all my young friends. I'm really excited to have connected with you. I feel younger. I feel happy. I think the greatest opportunity we have, especially to stop infections, because we know that HIV moves from people like me who have the virus to people who don't have it. So what we are doing is to encourage people, and that's what I mentioned in my presentation earlier, by us here, older people, to act as role models. Every young person wants to grow up and become like somebody who is older and be somebody, a doctor, or an influencer in somewhere. So the most important thing we are trying to do, especially, is to support these young people to solve their medicine with good adherence. That's the best we have. There are now better things, like people are swallowing only 1 pill, others are, we're now even having people who are getting an injection once 2 months. So, and then the other issue is what I would call treatment literacy, helping these people know the disease. It's like knowing your enemy, and then coming up what you can do to overcome them. And in this case, we know that if you have HIV and you take your medicine with good adherence, then the viral is suppressed, then you not infect others who don't have. People will have, young people, of course, are sexually active. We can tell them to, especially when they're at school, to abstain, but they cannot abstain from sex forever. But when they are sexually active, then they need to use this. But we also have to use the other, what I call combination prevention. Viral load suppression is indeed, I think, at the forefront, but using other methods like condom use, and so and avoiding really risky behavior like drinking alcohol. That makes excessive drinking of alcohol makes people the decision-making mechanism affected. We, of course, also want to fight stigma. Stigma is at the forefront of making many of these people not be able to talk about it. So stigma is based on myths, misconceptions, and really half-truth, if any. So the only way to overcome it is giving people information correctly and consistently. But you cannot give information if you don't have it. So we must be knowledgeable ourselves. So that's why we need researchers like what is being done, produce evidence and information which we can share. I have to drop off for another engagement, but I put my WhatsApp number in the chat and also my X. You can follow me on @Watiti Stephen, and let's continue the conversation. Thank you very much.
Yeah, thank you so much, Dr. Watiti and Spain. Thank you for today's webinar. It has been good and enriching to listen from you. And as I said, we can be able to continue interacting with him. So I guess I'll be able to give, I think, a question to each of the panelists, since Dr. Watiti has responded to some. I know some have been answered in the chats, but I'll just try really to peruse through and see what can be able to go. Yeah, Edmond Batema, thank you so much. You say, Dr. Watiti, how can we best support adolescents that are not suppressing and are in school? And I think, Tumine, thank you so much. You've responded to that. I think the government should initiate a policy of HIV screening for school-going children, and the counselor to handle them at all levels. That's really good. And in all institutions, because we find issues of students who are HIV positive and they aren't known to the school administration to give them special attention at all times. That's poor viral load suppression. And these students really need continuous monitoring by counselor. Yeah, thank you so much to me. That's really so important, and we need to take note of that. And Dr. Watita had left. Dr. Watita had responded to the question from Wilbrod. Thank you so much. That question has been responded to. The others that have been responded to, and I think I'm just going to pick one for each one of my panelists, maybe to throw more light about that. And Fiona, I think could you maybe throw more light on this? Tau says for patients with suspected viral failure, even in face of ongoing adherence problems, should treatment switching be considered, and is likely to do? What is it likely? I think he's talking about also resistant mutations. So I think, could you tell us something about switch over? When do you switch over? What do you consider switch over from one regimen to another in the face of the new HIV treatment guidelines that have been launched out, not only in Uganda, but East Africa, where the project is taking place? Thank you so much. Over to you, Dr. Fiona.
Okay, thank you very much, Dr. Benjamin. I'll use your microphone. Currently, Ministry of Health recommends that every person living with HIV with a suppressed viral load should have HIV drug resistance testing done. However, it's important to note that before you switch the regimen, there are very many socioeconomic and psychological challenges that will be transmitted or moved on to the new regimen. So it's important that we do a holistic assessment and implement holistic interventions to combat those barriers to adherence. And after we have solved those, then we can go ahead and switch the regimen based on the HIV drug resistant result and ensure that the client is adhering moving forward. Thank you.
Yeah, thank you so much, Dr. Fiona. And I know you're doing a lot down there. There is, I think this will go to Elinor Wanyama Chemonges. I think Yvonne said, hello, my name is Yvonne. I think she said, they wrote messages by young people, like drama poems, were they recorded? If yes, how can one get access to them? I think, no, this one, I think Yvonne was requesting about the engagements and the recordings which you've made, and I think Dennis said this will be accessed from the TGHN website. Yes, I can see that. Yes, this one was talking about how can we prevent online abuses towards adolescents and young people, and I think this can't be answered. This can best be answered by community and stakeholders engagement. I don't know if Dennis or will take this.
I can start. Okay. I'm sure that if we worked together, we could establish some safe sites where we can have young people asking questions, and we have healthcare workers, we have experienced people like Dr. Watiti answering them. So I think in future, this is something that can be considered in programming so that we have safe spaces online where young people can go to and ask questions. And we have healthcare workers, we have counselors who can respond to these questions. We also, during this study, have established WhatsApp groups. And in these WhatsApp groups, we have counselors, we have clinicians joining in to answer some of the questions and respond to some of the issues that young people are asking. And the good thing is that these platforms are managed by the young people themselves. So sometimes when they do not want these clinicians or the counselors to be part of it, they can easily remove them and then put them back when it is convenient. Thank you. Dennis, you can go ahead.
Yeah, thank you so much, Elinor, for that response. I think in the interest of time, Dennis will be able to combine with this I know it was addressed to Dr. Watiti by Wilfred, but I think Dennis also can be able to respond to that. How best can we engage illiterate young people who are living with HIV to ensure that their views and opinions are considered in policy making and decisions? So they're literate, and I'm sure you must have encountered them as you've been working with the people. So please, could you respond to that? Then we'll be able to go to the next item. Thank you.
Yes, thank you very much. So from what we've been able to compile, most of the young people have said that it's good for the project or program implementers to go down in the communities and talk to them in the communities where they are found, and then also use languages they understand, because you know most of these are not literate as most of us. So translate the materials and communicate with them in the languages they understand. Yeah.
Yeah, thank you so much. And I think, Wilfred, that was also well represented through the skits, the drama. You saw that they were speaking close to 3 languages or more, including Swahili, which is widely spoken here in East Africa. So I think the essence is really to reach out to them, explaining the language they understand, and break down the scientific jargons such that you can ably represent their views and opinions to policymakers. Yeah, thank you so much, the team, especially the panelists. I've enjoyed really listening from the knowledge from you, and I'm sure a number of us have learned a lot. I think at this time we have responded to most of the questions in the QA section, and we have a brief survey, a poll that we are going to conduct. I'll request members really to be attentive. We just want to assess and see the impact of this webinar, what information it has helped us. It will be like 2 to 3 minutes. Yeah, so I just want, I know I have like 2-3 minutes, and I'll just comment about something really. Do you know your HIV status? At least 91% of us have responded yes, but we still have the 9% that have said no. I would encourage us to, at least as we celebrate the World AIDS Day, we move to the health facility and at least you know your HIV status, because the first 95 goal is 95% should be able to know their HIV status. When did you last test for HIV? And we can see that amongst those ones who have said they know their HIV, at least 36% have said in the last 3 months, which is really good. 20% in 3 to 6 months, 18% in 6 to 12 months, but also we have 27% more than 12 months ago. And what does HIV viral load suppression mean? We had at least the majority, 73% says it means the amount of virus in the blood is low, which is okay. But then we have people who are saying amount of CD4 count is low. And I've been corrected by the facilitators that actually the right answer was the amount of virus in the blood is low. So CD4 count cannot be, when it is low, then actually we know that chances are high that the viral load is high. And the person is very sick, at least no one took that one, and we have 5% who said none of the above. So the right answer is amount of virus in the blood is low. And the next one, which was question 4, was what point of care HIV viral load monitoring involves. Okay, the point of care HIV viral load monitoring involves the following, except. So except what? And at least except client waiting for 2 weeks to get results, and that's at least 63% managed to get it. Because point of care means that the test results are given on the same day. It means the test is done at the site and blood sample is taken off at that very particular visit. Then we have what means can we use to best communicate issues of viral load suppression. I think this was really open-ended question. So I'm happy that you see songs, poetry, dance, motivation, speak, and you've seen some of these ones as people are responding to. Are there any advantages of point of care viral load? At least 100% said yes, which is good. And I'm sure the team should be able to continue with the study because people believe there are a number of advantages from point of care HIV viral load testing. What level of knowledge did you have before this webinar? And of course, we have seen some people responding. Like 39% say, I have a strong understanding and want deeper knowledge about what was happening. And I hope this has been addressed. Yeah, thank you so much for tuning in today and listening from wherever you've been. It has been an interesting 1 hour and 30 minutes of us learning together, and I've enjoyed really being the chair of today's webinar, one of its kind, where several languages are being communicated, several facilitators, including videos. And we just want to really give credit to these young people who are living with HIV, who have gotten out of stigma and have managed to put this together and showcased their talents it's really good news as we move towards 1st December when we are celebrating the World's AIDS Day. Thank you so much. We want to appreciate the funders, we want to appreciate the partners, and we want to appreciate the facilitators. We are grateful. Thank you so much.